So first thing I would like you to get your minds into the idea that lymphedema is a global problem. There isn't one country in the world that doesn't have lymphedema. But it actually matters where you live in the world about how you think about it. I've had the privilege, and Peter as well, to go to places like India. I've been working in Africa. I'm going to Uganda next month. And suddenly you see this huge global problem, but it's completely hidden. It affects the poorest people in the world. It affects people, if we think about where we sit today, people in India are sitting in houses where they've got no running water. I went to Uganda in March of this year, and it took me 13 hours to get to an island to see 2 patients, which also required me to do a 4-hour walk, which was quite challenging. And actually, in Uganda, there was a boy of 8 with lymphatic filariasis, already had a hydrocele, having every month an episode of cellulitis. He came with his uncle. And at that visit, there wasn't even a packet of gauze. There was nothing. They are not taking drugs. They are literally without anything. So the world of lymphedema is this huge spectrum from high science and genetics through to the poorest people, where the biggest burden is in Africa and India, who've got absolutely nothing. Now let's see if we do. So if you were to live in India or Africa, and these are all my pictures from my visits to India and Africa, you would be thinking of lymphedema if you thought about it at all, but it's a neglected tropical disease. It's spread by the mosquito. And a lot of the work that's been done in that world is about developing the drugs to prevent that transmission. And it's been quite successful. If you read the WHO guidelines, you'll hear that Togo have no longer got lymphedema. Not true, because actually in many of these countries, they don't just have lymphatic filariasis caused by a mosquito, they have all the other sorts of lymphedema that you see. How many here has ever seen a patient with filariasis in their clinic? One of you. And Peter, probably you and I have seen one. So we don't see filariasis. If you look at the top, that's the shack of one of the patients I went to see. He has no running water. He has been under the care of Dr. Narahari. So the very, very poorest populations are suffering horrendously. This patient on the right in the middle is under Dr. Narahari in India. And look at her, look at the leg. This is a patient who's been treated by a centre. So we are talking about the very poorest people right through to the richest people. And I wonder if you know that the worst reimbursement and access to care actually isn't in India, it's in America. So when we think about it globally, and I've had the privilege of working in sort of more of a public health role, and it's been it's incredible. There are still people walking around the world who never get a diagnosis, who never get any treatment at all. So it's a really, really massive global issue, and that's what we're committed to trying to do. Well, I'm not going to talk to you about what lymphedema is because Peter's going to talk to you about this. But actually definitions and etiology and what we're describing is a major problem for us. Because unless we can do that well, we can never really develop the treatments that we really want. So we have umbrella terms. And it was actually when I worked with Peter, you remember this work, Peter? Absolutely. We developed the term chronic edema. It was about 1998 we started to think about how do we encapsulate all the different patient groups? And we started to develop the term chronic edema. It's not a diagnosis, be very clear. I am not saying to you this is a diagnosis, but it's a term, and it's a public health term. And we used it in our first study that we did in London, and we've used it in the work that we've done since. Because it's a big heterogeneous population. It's massively complex with so many different groups. So when we talk about the word chronic edema, please don't think we're talking about a diagnosis, but we are talking about a public health term that reflects the many different groups that you see, and Peter, you'll hear much more from Peter around the issues around different etiologies. And we've realised it's really useful to have this term that people can start to think about the diversity. Peter will talk to you about primary and secondary, but even that is a minefield. It's a minefield. And in many countries of the world, like Italy, for instance, the reimbursement is linked to whether you have primary lymphedema. And if you have secondary lymphedema, well, you're put on the back burner. So actually, the diversity is not easy. And a lot of the work that's happening globally is in the primary group, and it's very, so you've got the world's leader, and Georges are one of the, well, if not the world's leader, in the genetics and understanding primary. But secondary is also far more complex, and Peter's work is showing that it's not just about things like cancer, there's probably also an underlying genetic predisposition. All of this work's going to be exposed, I'm sure, in the next few years, and Georges is certainly leading in that. But if I take my hat off and think about, I'm a clinical academic, I've always treated patients, and I'm passionately a clinician, I work in Denmark as well. Lymphedema links to so many complex populations. And I just put this slide up. These are all patients that I've seen. Head and neck cancer. I mean, the horribleness of head and neck cancer. How do we treat that? There's still people presenting, especially after COVID, with fungating wounds because of secondary cancer that has been ignored. We've still got the issues of the link between people having leg ulcers, both venous and other etiologies, who've got chronic edema. And we've got the exploding issue of the role of morbid obesity. In some parts of the UK, services cap how many patients they can take with morbid obesity. And this is something that's, it's beyond the scope of this talk, but it's really, really challenging. How many patients that we have from these many different groups. Something that's dear to me is the issue of obesity. There is a very, very strong link in terms of obesity and the development of lymphedema, even in the breast cancer populations. But increasingly our understanding that when you've got morbidly obese patients, it's inevitable, dare I say it, Peter, I hope you support it, it's inevitable you will have some form of lymphedema developing because they just will get it. And the solution, what is the solution? We've got a data set at the moment, 10,000 patients, and we're beginning to try and understand about what do we do with these patients. They are horrendously complex. I know at St George's, Peter doesn't mind me, I'm sure saying, they used to be admitted for inpatient care, yes? For 5 or 6 weeks, and they'd lose masses of volume, there'd be massive input, it would be fantastic. Then they'd be discharged 6 months later. What was the situation? And I do not propose to tell you there's a quick fix, because it's anybody who tells you there is lying to you. Because this is a complex problem with bariatric patients, but they need our compassion. That's what they definitely need, is our compassion. And of course, I don't know where you all work, but gone are the days of simple health services. I mean, I work in Nottingham Hospital. We're always on what we call Opal 4, which is so depressing. It means there's no beds, there's no discharges, there's no community, there's no access to move anyone, and there's 28 ambulances outside waiting to deliver patients. So if you think about, we are heading into an elderly population, aren't we? How many of your patients are simple anymore? I mean, none of my patients I see are ever simple. By the time you get to be 70, you're likely to have 2 or 3 comorbidities. And when we think chronic edema as that broad term, we shouldn't just think about cancer, but we must think about it. Still, over 20% of people with breast cancer are developing lymphedema. That's even with the best interventions. And all of the other cancers, they're all associated with a lifelong risk of having lymphedema, but it's probably only 30% of all of our chronic edemas are cancer patients. What about your cardiovascular patients, Your venous ulcer patients, the mismatch between thinking about where venous disease in some way is disconnected from chronic edema, it's rubbish. They always have chronic edema. What about neurological diseases? We've done work in an MS population. 62% of patients who've got very late stage MS have got chronic edema. Most of them didn't even know it was an issue. And all of the neurological problems potentially lead to chronic edema. And then, of course, the whole breadth of lymphatic disorders I won't touch on because Peter will do that. Dermatological problems. Late-stage chronic eczemas develop into chronic edemas. So, in a way, the radar needs to be open, doesn't it? We need to get people aware that chronic edema is something that everybody should be aware of, everybody should be looking at. You know, if we think about things like how pressure ulcers have become so emotive, well, chronic edema needs to be the next emotive. 38% of people in acute hospitals in Europe have got chronic edema. They weren't admitted for it, but they have it concurrently. So very complex, very big, but everywhere, in not just healthcare, but in social care as well. How do I begin to tell you how it affects patients? Well, I could be here all day, and I promise I won't. But there is a massive impact. Whether you're a child, whether you're an adult, there is a massive impact. But it's not all bad news, because the main messages are, when we get a handle on someone's swelling, when we get a chance on reducing their cellulitis, when we treat them, yes, their quality of life improves. So we need to have that as a message. It's not just an inevitable sort of failure. We can do something to make them feel better. What's it like to live in India and Africa? This is a patient, one of the patients that I saw when I was in India. Well, in India and Africa, what do they care about? Well, the WHO care about how many pills are being taken by the population to break the transmission. But there's very little focus on morbidity. How do you live like this when you can't work? The knowledge, professionally, worldwide, is appalling. It's one of the things that ILF are trying to address. Professional knowledge is appalling. There's fear in some cultures, not so much, I think, in the West, but in places like India and Africa, lymphedema is thought to be because you're bewitched. So you're put out of your community. It's that, and we don't really know. How many patients have you seen with large legs who talk about how they don't go out, they don't socialise because of the stigma and the shame they feel? Poverty. You know, poverty is not just about whether you live in India, and it's easy to think, well, that's all right. You're talking about India. Poverty affects lymphedema patients in the UK because they have to give up work very often. Their benefits don't cover. They have to make adaptations. So these people suffer with poverty as a consequence of lymphedema. And in many countries of the world, there simply are no access to dressings and management. How fantastic. You've got a whole, wonderful to see all of you industry here. Part of ILF's belief is the partnership with industry. You know, it's about seeing this growth because it's that growth of industry that gives us solutions. But I wonder how many of you realise in India that the bandages in a hospital cost 80% of the care costs, and they have to get their bandages from Europe. So there's some scandals out there around, and these are things that we're trying to look at as a framework. And then, of course, in some parts of the world, you never get to see someone like Peter. You wouldn't have a hope of seeing someone like Peter. You'll go to traditional healers who'll believe that your lymphedema is in your spirits, and they'll cut your leg to let out evil spirits. That's still happening today. So it's very complex. It's fascinating, but it's complex. So our evidence is you get reduced quality of life with all sorts of lymphedema, and there is social stigma, impact on employment, implications for families. Don't think that pain doesn't happen with lymphedema. It does. Many patients, their first symptom is actually they get pain before anybody's been even aware. They start to get defined swelling. But treatment improves quality of life. What we don't know very much is what I call the societal impact. This is a lady I interviewed in India, and she's beautiful, isn't she? She's so beautiful, but she told me, I can never marry. I have to be looked after by my family. No one will ever marry me. It's an arranged marriage country. So I wonder how many of you have ever looked at how many people with leg ulcers don't have partners. 40% if they have an early leg ulcer. So these are things perhaps we never think about, whether you feel beautiful. Actually, these people often don't, and then they develop psychological problems as a consequence. In the West, and I use the West a lot, very briefly, I mean, kind of like, but edema and obesity and all of the comorbidities are growing because we're getting older. As we get older, we are having an increasingly elderly population, and we know that chronic edema is highest in the very elderly. We're seeing an explosion of obesity, and we are going to have to face that and find solutions for lymphedema services, and services are ground into the ground by trying to manage morbidly obese patients. People are becoming less willing to walk, and we need mobility exercise, don't we, to move our lymphatics. And yet, you know, how many people do you see on scooters or in wheelchairs? You know, it's a real issue. And of course, as we become more successful with cancer treatment, so we're going to have people living with cancer simply as a lifelong condition. And lymphedema doesn't develop all in the early stages. You can get it 10, 20, 30, 40 years later. So it's something that we need to try and get people to get a handle on. It's never going to go away, this problem, because it's so complex. So we need to care, don't we? Why are we here today? Because we deeply care. And I really congratulate the work of Ireland to pull this together. Get behind them, please. Get behind this team who are trying to make a difference. Because part of the ethos of ILF is together we can do anything. And that's really a message I want to get across. How do people come into the system? Sometimes it's very insidious. What's normal? If you all look at your feet now, well, I'm not suggesting you do, how many of you are used to having swollen legs at the end of the day and you never think anything of it? Sometimes it's so insidious. People think just part of growing old. Professionals don't take any notice of it. What happens is you only notice it when there's a complication or something goes wrong. Family members normalize it. Well, my mum's always had big legs. Excuse me. We've always been it. Perhaps you're talking about someone with primary lymphedema because there's 4 generations who've always had. So this idea of normalization is a real problem. Just annoying. Had to go up a shoe size, when actually maybe they're on this trajectory of developing severe complications. Chronic edema, well, you're just fat, you know? And of course, some of it can be obesity, but it's not the solution, and it's not necessarily the diagnosis in many patients. But sometimes, I don't know why, but suddenly this word came into the middle of this. It's very strange, because it was all right on my computer. Suddenly, sometimes the journey is very different. It's very sudden and it's very terrifying. The shock of getting through cancer and then having lymphedema. And patients in the research have said, you know, I cope with cancer, but my lymphedema is a daily reminder of my own mortality. It might be suddenly produced because of complications after surgery, a seroma or a hematoma, or a complication of surgery. People are weighing up, is this still the effects of surgery or have you got a lymphedema? The issue is about prevention versus treatment. Sometimes people become acutely sick, and very often they develop their first seeing in a health service with an acute cellulitis, and no one's got any idea that this is the precursor to having lymphedema. The idea these patients get lost, they get delayed in referral, or no referral. And yeah, this is something that says a lot about the state of the art in terms of recognition. So I'm going to share with you some work that I've done. I did a big study called Limprint, which in Ireland, we're very much part of this. 9 countries, 41 sites, 14,000 patients. We're still carrying on with new sites. But I want to talk to you a little bit about cellulitis and what we found in that. So everybody's aware, I think, or increasingly aware, that cellulitis occurs in chronic leg edema. I wonder how many of you know that actually Hippocrates recognised the role of both leg ulceration, leg edema, and cellulitis. But we were interested in this issue of trying to look at it. So we've done analysis looking at leg cellulitis, and I'll share with you the results of our arm cellulitis. So what sort of issues do we face? Well, first, to recognise that you're 7 times increased chance of having a cellulitis if you have an uncontrolled chronic edema. And that's a message I'd like you to remember. What's it like? Well, it's pretty bad if you're a patient, and this is a fairly classical presentation of a cellulitis. There's a whole variety of ways in which people present. I hope, if I don't talk too much, to show you a video from one of our patients in Denmark who's had 33 episodes of cellulitis post-cervical cancer. And of course, it occurs in any body part. So we're kind of aware that cellulitis hospitals are aware of this. Actually, it's 1.4% of admissions based on our NHS data were from cellulitis. And how many of those people have an underlying lymphatic problem? If you take Robert Damstra's work, it's 60 to 70% have got a problem with their lymphatics, which is why they develop a cellulitis. So it's a really, really big issue, and this probably is not the complete picture at all. So it's affecting us in acute hospitals. But the trouble is we don't get these patients correctly diagnosed. 30% of them get misdiagnosed. So what do they, well, firstly, they get people with uncontrolled chronic edema have red legs, often bilateral, and they get diagnosed as having cellulitis, and it's simply got red legs, okay? Or they get described as having stasis dermatitis, or they just get described as having contact dermatitis, or deep vein thrombosis, or superficial thrombophlebitis. So we are hideously poor at diagnosing cellulitis according to where you end up with, which clinician you end up having. We also have this awful insidious nature of people deteriorating. And one of the things that I've learned to really respect is the staging of the International Society of Lymphology. It's a very, very simple staging. And when I first started to use it, I have to say I was pretty, well, this isn't going to show much. It's too global, but actually it's really useful. Because actually these stages, you obviously can see it's showing a difference. It doesn't mean to say people necessarily use the staging particularly well, but actually this is often the stage that we end up seeing people, so late stage 3. By then, horrendous tissue changes, some of which are reversible and some of which have become irreversible. So our study in Limprint, we wanted to look at how many people with leg swelling have cellulitis. And we had 7,477 patients. 40% had had cellulitis at some point in their life of having lymphedema. I was very honoured because it was published in the British Journal of Dermatology, and Peter did the editorial for this study, so it was very precious to me. 40%. But, do it right, 16% in the last year. And of that 16%, 40% had had more than 3 episodes, and 60% had been admitted to hospital. So this is a really, really important problem that we can't ignore. And of course, we all know about the complications medically, endocarditis, osteomyelitis. Ignoring this leads to horrendous problems and causes the edema, of course, to get much worse. But how common is chronic edema? I was thinking about trying to present Limprint with you, and I thought I haven't got enough time. But I can tell you from the studies we've done, 60% of patients in community being looked after by nurses, 60% have uncontrolled chronic edema. And that's based on a study with prospective evaluation of every patient, 2,600 over a month, every patient was examined. 40% of people in acute hospitals. So it's really, really common, and yet it's hidden. Yet it's hidden. Isn't that incredible that we find ourselves in this state? Many of them are in that stage 2 or stage 1 phase, or as I'm sure Peter will talk about, is the latent stage where nobody's even thinking about it. But it is not an inevitability that people have to progress down to this awful stage 3. So, what makes you more at risk? Obesity, especially if you've got a BMI over 30. Being male, we've got no idea why being male increases your risk, doubles your risk of having cellulitis. Diabetes, well, we actually found some fairly interesting contradictory results, but of course, diabetes, of course, is a very important condition. Having a wound. So, 80% of the patients have got concurrent wounds. If you've got skin disease and your skin is not, the barrier function is gone, you get cellulitis. In India, the patients who got a poor barrier function, they got cellulitis in India. What did they do in India? Well, they increased the skin care, got the skin in a better place, and what did they find? Their cellulitis went away. Basic stuff. Fungus infection. I think Peter's right. I remember Peter saying to me 97% of people have got mycosis with lymphedema. He might contradict me, but I'm sure him telling me one day clinically. So mycosis is part of having lymphedema as well. So when you lose your barrier function, you're at risk of having cellulitis. And most importantly, by the time your chronic edema gets really bad, you increase your chance at least 7-fold. Okay, and the more severe you are, the more your changes in tissues, the more the risk that you have. But something I've never shared, and this is the first time I've ever presented this, I saved it for you, Maeve, Nora. We just analysed our arm patients. We've got 2,000 of them in Limprint. As you would expect, most of them are female. Only 2% are primary, most of them are breast cancer, as you would expect. 20% have got midline swelling, so that's important. And 11.2% have had a cellulitis in the last 12 months in the arm population. And what makes you at risk? Long duration of swelling, poor control, and severe severity. Not rocket science, but even in an arm population, which we think, well, maybe we've got it sussed how to treat breast cancer, maybe we haven't. I'm not going to really talk about this, but prevention of cellulitis is about getting the treatments right. It is about getting the basics of compression, of use of antibiotics, of skin care regimes. These are the things that make the difference. And we've got to get on top of this reality. We will not change cellulitis or people's lives unless we can actually offer effective treatment. The patient on the left, this patient came into me when I was working in Derby with a 4-layer bandage on, and this was the picture I took. Well, you're like, that's horrendous. But it's not surprising because they took no account in the community of the toe swelling was developed. The patient's had mycosis, has now got infection, has now got osteomyelitis. So we've got to get the basics right. We can't just, it's not all about high science, it's about getting the basics right. If we put on stockings and they don't fit, what happens? They throw them out or put them in the drawer. I mean, we've got fantastic garments now, but the wrong garment on the wrong patient, well, it's quite simple, it won't work. And of course, you've got to remember complexity. So people with autoimmune diseases, where the use of things like compression need to be done more carefully. But complex decongestive therapy is vital. I cannot say to you enough about this, and I haven't got time to say to you the importance of skincare, the role of exercise. Please don't think I'm not focusing on it. It's simply I haven't got time. Skincare, prevention of cellulitis, prophylaxis of cellulitis, exercise, fantastic, but compression. Compression is the absolute transformational part. Not only does you can't reduce a complex patient unless you use compression. And your compression reduces your recurrence rates. And that's the really, really important message to take away. And it's awful for patients to suffer. What's it like to be a patient if you don't get treatment? This still saddens me. Patients talk about getting to the point of diagnosis. They get an incorrect or a delayed diagnosis, especially the primary patients, where they can take 4 or 5 years in some countries to get to the right doctor who's going to make a diagnosis. And on that journey, they might have been given wrong diagnosis, wrong treatment, wrong advice. And then patients can develop fear and mistrust. We've got to deal with professional knowledge. And the patients who are not offered this can sometimes appear to be really difficult. The lipedema group is another group, isn't it? I mustn't digress into lipedema. But lipedema patients can sometimes be really up there and like, I demand that I have, this treatment. Why? Because they're desperate for a diagnosis, for the correct treatment, for the correct advice. And these things are really, really important. Often patients end up being completely desperate because they're left without care. I want to talk a little bit about reality for patients. This is this picture of cellulitis. What's it like to be a patient who's got cellulitis? Our research shows people with lymphedema talk about living on the edge of cellulitis. They never go anywhere without their penicillin in their handbag. It's like having a nut allergy. Because it's so rapid, it's within 20 minutes. And for parents of children, 30% of children with lymphedema have a cellulitis before the age of 10. So imagine being a parent and, with that. So it affects how they look after their children because of the fear of living with that. We did a big study, Maeve was there, a big piece of work on a children's camp, which we've published. But it was a very complex method, so I won't go into that. But what was it like to be a parent? Well, you've got terrible shock. The fear about your child and how to look after them. The fears around disease management, which is why I'm so passionate about ILF, saying that every single country must have a specialist lymphedema service that is like the one at St George's and Derby, because it's a very complex disease. It is not something a GP can just manage. And I'm doing a national study in Denmark, which is wonderful, and I'm picking up people who are aged 20 who were given a diagnosis of primary lymphedema when they were 13, but nobody actually knows what their condition is. So, it's awful for a rare disease, and we really need to push. And the wonderful work, it's not just ILF. I love working with Learn, because Learn are doing something around specialist services, and ILF and Learn work a lot with that association as well. And parents, not just parents, but patients struggle to know how to live with their condition. Do I do anything? How many patients are told, don't have an injection in your arm? Even if you're dying, you mustn't have an injection in your arm, you mustn't have your blood pressure taken. Some of the things that we have embedded in our reality are not based on science, they're based on myths. So it's complex, and I know I must watch time, I know, because I'm talking too much. So in terms of cellulitis, we can reduce that. But I want to share with you now just a short video, if I may, about a patient in Denmark. Now, I work with the Wound Healing Centre with Tony Karsmark, who's a wonderful team. And this is a beautiful lady who's given me permission to share this video with. She had cervical cancer, age 20. She had a full pelvic clearance, and she has her story. I'm going to tell you about her because I know this story. So she had cervical cancer. Well, she'd gone through all of that. And before she developed lymphedema, in the 6 months before, she had 4 episodes of cellulitis, 2 of which required her to be in intensive care. Since then, she's had 33 episodes over a period of 7 years. But actually, what her story tells us is about what it's like to end up in A&E with a fever of 42 and clinicians not having a clue what to do, and also the reality of how she's learned to manage her condition. And actually what she would tell you is that now she knows how to use her antibiotics. She can control an episode within 2 hours. because she knows what to do. But she's had 33 episodes, and that's in a good centre. So cellulitis is a really horrifying issue. And I take you back to India and Uganda. The first patient I ever saw in Uganda was an 8-year-old. He had a big hydrocele. It was awful. I stood there on this island with nothing other than my phone and on my camera. I took a picture, sent it off to Dr. Narahari in India. I said, I just want you to see this. And he said, yes, I know what this is. This is lymphatic filariasis, stage 3 with hydrocele. I said, I know, I'm just telling you. That child is 8. Since the age of 5, has had an episode of cellulitis every month. So this is a really global problem, and one that we really can control. It's not inevitable. We really can control. So forgive me, you're not missed anything. But in finishing, because Maeve and Nora just wanted me to tell a little about what else we're doing, just a little bit about the other projects. So we've got a project called Chronic Edema Outcome Measures, and we're trying to get better at doing this. So I'm going to go through it very quickly. You don't need to. Our Limprint study, our epidemiology showed we haven't got enough attention on this. We've now got epidemiology that's beginning to show it's everywhere, but we don't have any standards or methods that we can all agree that's how we measure lymphedema, because actually they don't exist. And if you're working in a specialist centre, what you can do is very different if you're working in primary care or your GP surgery. So we're trying to get a handle on this. It's a big project, but just to give you, some feedback, we need to ask ourselves what we're trying to achieve. Are we looking at patient outcomes, healthcare system outcomes, the industry, society? So it's a complex issue. But I guess most of you are clinicians here, so I think a lot of you will be concerned about having clinical outcomes that actually matter to you. So what's the most common outcome? Well, it's actually the limb volume. But how do you all measure it? Everybody does it differently. So it might be you're just using a tape measure. If you're really lucky, you might have a machine called a pyrometer which measures limb volume, but it excludes the foot. So actually we've really need to have new ways. We've got new technologies. Go and talk to these guys. We've got wonderful new technologies that are really exciting. Bioimpedance, moisture meters, lymph scanners. I'm using a lymph scanner now in Nottingham as the way of defining whether someone has chronic edema. So the whole field's growing, and Natalie's at the back, so I'm waving at her. We've got new technologies, and we need to start getting them out there to you on the front line. But we know we've got a lot of work to do to get there. So our goal is to have a set of outcome measures. That's what we're trying to do. There's only 8 of us on the board, 10 of us on the board, so people think ILF is very big, but we're not big, and we've all got day jobs. But we're working very hard, and our lifeblood is our frameworks, and that's why we can do anything. We did a survey, an international survey looking at what outcome measures were used, and we've done a systematic review, which we're in the middle of, a qualitative study. So let me tell you a little bit. Our survey, I thought the survey, well, maybe if I was lucky, I'd get 100 responses. Actually, what we got, I'm not going to talk about how we validated because it's too long. We had a simple survey, went out on SurveyMonkey, 8,000 respondents. 8,014. 12 frameworks. Ireland were brilliant. 61 countries. And we got this amazing glimpse into the world of what people thought about what outcome measures we need. We had patients' feedback, we had healthcare professionals, we had industry as well. And we used not just our frameworks, but social media. Now, all of these posters, you can't read them, don't try, but they're all on the ILF website. You can see them all. But I want you to also see that social media is really, really good. 50% of the people were patients. And how do you get to patients? So, social media, I'm very technophobic, but social media is really, really useful. We've just done a study with 500 children with primary lymphedema, 500, and we've done it entirely through social media, and it's validating a disease-specific tool. So even though technology causes me to have palpitations, the world we're in is a new world. what are people doing? What did we find? Well, patients said that the most important outcome was their limb volume and whether it was stable. And not surprisingly, so did the professionals. That's ignoring the fact that we all do it differently. Quality of life was the next most important by patients, and it also was by professionals, even though we don't necessarily all know what we're talking about when we mean by quality of life. Patients, well, symptoms under control was their next priority, whereas for the professionals, it was the ability to self-manage. So you can see how these things can give you some textual things about where to put your energies. And have a look. There's Ireland. There's your team here in Ireland. This is their poster. This is the work they did. I'm really, really proud of the Irish group. They've always been completely committed to us. So go on to ILF and have a look at the Irish. And this is just to show that every single country had a poster, celebrated at our conference, and it's part, again, about the family approach we have to everything that we try to do. If you ever want to do something awful, do a systematic review. Anybody done one here? Peter. I'm joking because I'm supposed to be an academic as well, but scoping reviews and literature reviews are hugely time-consuming. They're really, really important, but they're really, really time-consuming. But we, in our wisdom or lack of it, decided, well, why don't we do a nice narrative review to see what the world's using for outcome measures? And we'll look at it, both adults and children's. We'll do that. Walk in the park. Well, we did our search strategy, very boring. You don't need to worry about that. Typical thing about how you do it, how you screen it. There's all sorts of methodology that we all have to face. It's very boring for a Saturday morning. I won't bore you with it. It included all types of studies. They had to be in English. And it was everywhere from 2003 to 2018. In fact, now we've made it 2022. So that's where we started. We had all these fancy keywords. We had a librarian did it for us properly, and it was all using something called Covidence. Again, extremely boring, not for Saturday morning. But what we got, nearly 8,000 papers, of which we had to read all of them, the abstracts. It's a great thing for insomnia. So we finished the titles and abstracts by 2019, and now we're in the pleasure of reading the full text of 4,000. And I'm told reliably or unreliably, but we'll be finished by the end of the year. I doubt it. But nevertheless, it's proving to be very illuminating that we really don't have any sort of idea around the world what outcome measures people are using, and they're not using it consistently anyway. So I suppose it's told me what I knew already. We did a lovely study with industry, because one of the things that I think we never focus on, what's it like to be in industry here? Pretty tough. And I really appreciate that the industry are, again, they're your partners in taking things forward. But I wanted to ask industry, what's it like to get reimbursement? Well, they tell me don't go to France because it's awfully hard. But actually reimbursement and getting new products to the marketplace is really, really tough. And it's really tough as well because we have this word compression, which, what does that mean? Well, you've got different classes, and you've got different ones in the UK to what you've got in France, to what you've got in America, and then you've got different fabrics, and then you've got new devices. Is it a device or is it a non-device? It's really, really tough. And I learned so much that I hope will help me work better with the industry to help them get the products to you. Because that's really what we need. And unfortunately, some organisations treat industry like they're the black sheep of the crowd. And that is just ridiculous. Our industry partners are the reason why we have innovation. They have fantastic products, but they need us, and believe me, we need them even more importantly. So, what else are we doing? We finished our quality of life tool for children, so that's going to be really ready. I've got some other tools looking at self-management. Hey, wouldn't it be fantastic to think about how to self-manage and to have a research basis? We're looking at self-management. We've got some new tools for that. And we've got a conference next year. And the conference next year is in the UK in Nottingham. And of course, your framework are central to that. They will be offered, as always, free places, and we want you to share with us, please, all the work you're doing, because it's actually that sense of working together that enables us to make progress. And I was talking with Peter earlier, you know, when I think what I thought I knew in 1993, I realise I didn't know anything, and I know less now. What I mean is our humility in staying open and not saying we've got all the answers. Anybody who tells you they've got a service and they heal everybody or they all get better is lying to you. Because we're all struggling, we all struggle, but actually many of our patients, this is a slide I took from patients we see in Denmark, and Danish patients are very similar to UK patients, massive problems with obesity, long challenges of diagnosis. But for a patient with lymphedema, life can be very, very complex. You know, and we need, when we think about this world, we need to think, what's our goal? Our goal is to help people live better, to be able to engage with life better, and not feel that that condition is so dominating that they have no future. And I remember, Peter might remember this patient we had at George's many years ago. And she came in, she was a young girl with sickle cell, she had the most awful leg ulcers and edema. And she came in and she said to me, I can't cope, tonight I'm going to finish my life. She was 16. I remember talking with Peter and we admitted her and got her stable. And it really, those cases remind me of humanity, remind me that we have a responsibility and we can make a difference. And our difference is everything from being able to offer diagnostics and genetic testing to being able to have a relationship with someone who's dying within 6 hours of terminal cancer. So that spectrum of what we offer is so wonderful, and we need to do that as an interdisciplinary group, don't we? That's what we need to do. And I feel I've talked for too much, but I hope it inspires you that we're trying. You've got a group here who are trying so hard. Get behind this group. Please, get behind them. Every one of you is vital to what they achieve as well. And they're doing some great work in Ireland, and I'm really, really proud of them. So get behind them and help to make Ireland a gold standard in lymphedema treatment.